moving on to a slightly different area, but an area where there's been an incredible amount of data in the last few years, and that's the best approach to metastatic hormone-sensitive prostate cancer. So lots of therapy has been in castration-resistant disease. But Chris, what do you think the best approach to treating metastatic hormone-sensitive prostate cancer?
So of course it was very easy until 2 years ago. ADT alone was the standard of care. So for the last 2 years, since Charted and Stampede reported on docetaxel, ADT plus docetaxel was a new standard of care. And then the situation got more complicated this summer at ASCO with Latitude and Stampede. So now we've got an advantage for ADT plus abiraterone compared with ADT alone. So the obvious question to ask is, how does ADT plus docetaxel compare with ADT plus abiraterone? And we did have some new data presented yesterday from Stampede at this meeting. And so these are patients who were randomized in Stampede at a time when both the abiraterone comparison and the docetaxel comparison were both open. And so they happened to be randomized between abiraterone and docetaxel. Now it's only 560 patients, it's not a fully powered study, but it's the best we've got. And the bottom line was that there was no significant difference in overall survival between the two. So I guess right now we've got two options. We've got ADT and docetaxel, or ADT plus abiraterone, and they're both acceptable options. So from a clinical point of view, I'm happy to give either. I guess if I was the patient, I would prefer abiraterone. I would regard it as more friendly, less toxic, less getting in the way of my life. Even though potentially it's treat till progression, which could be a few years? Yes, I mean we saw data from the Latitude actually yesterday looking at quality of life, showing a clear advantage for ADT plus abiraterone versus ADT alone. Having said all that, I guess the decision is going to be made for us by the payers. Because if I was the payer, it's absolutely obvious that ADT plus docetaxel is the standard of care.
So can I challenge you on that, Chris? Because actually, it's not A or B, it's B then A or A then B. So indeed, actually, the toxicity that we're concerned about, both of us are concerned about, has to be managed at some point in the patient's life. And actually, it may be more manageable for the patient to get docetaxel, getting it earlier, and actually, particularly if you're a man who has to pay for their treatment, which is not uncommon, particularly in North America, and maybe not in the UK, docetaxel is 18 weeks of an inexpensive generic drug, and abiraterone is, probably $20,000–$30,000 or more. So, in fact, a lot more probably, 2 years. And my biggest concern is that, it's not whether you get it, versus the other, A or B. You're going to get both at some point. And actually, I would argue that actually, A, we don't know yet if early abiraterone is better than late abiraterone, because Stampede and Latitude never asked that question, and therefore that's a question that's not been answered at all. And in fact, we really haven't yet compared properly docetaxel and abiraterone, because as you said, the trial wasn't powered to ask this question anyway. So I do think that we've ended up with two standards of care, as you've rightly said, and actually we still haven't moved this field forward very much through these trials, in my mind. I don't know, Bertrand, you want to comment?
No, I'm very surprised. Something I'm very surprised since Stampede and Charted is the reaction of patients with newly diagnosed metastatic prostate cancer when you say the reference treatment is ADT plus docetaxel. Very, very, very few patients refuse.
True.
And one of the big advantages is when you start, when you're done, and then you can go on vacation. When you're going to be started on abiraterone, we were speaking about it with Gert Atta, you're going to come to even almost monthly to 6 weekly visit to check your potassium, and also there is a lot of resource to be used. So meaning that, like many of guys in the UK, you've got a beautiful residence in the south of France, that's done to live 6 months there. You're going to have to be organized. And this morning I was in the non-prostate GU session, and I say what we need now is that kind of pazopanib, sorafenib trial, where actually we don't look at FFS, but we look at OS, one group starting docetaxel and then getting the abiraterone, but getting abiraterone in the APCCC consensus, meaning where we all agree that you should give abiraterone very early when they're becoming hormone resistant. And doing so and comparing both sequences, because otherwise there are pros and cons to the other. And my anticipation is that based on what the patient expects in life, if we are honest enough, like Johann said, anyway guys, you're going to get both. It's up to decide whether you start with your chemo and then you got Abi, or you got Abi and then you're going to get chemo. I'm not so sure 100% of the patient will go to Abi.
But I'm not sure that's a question that's worth asking in a big trial. Because I'd be very surprised there's going to be a meaningful benefit.
No, there is no difference. There will be no difference.
Yeah. So a more interesting question to be asked would be looking at the combination. You know, if you're getting ADT plus docetaxel, is there benefit from additional abiraterone?
And that trial will hopefully read out in the next 2 years, I guess, piece one. And I agree that's a very important question. Although I do worry there's a very good reason why, you know, giving those two drugs together could, you know, be deleterious, and we have to be, I mean, I'm hoping that's a positive trial. I think it could be a positive trial, but we've learned from other diseases, including breast cancer, that combinations are not necessarily better, you know, than serial therapy one after the other. And it does really worry me that we're giving a lot of our best drugs very early to these patients, and very early in their disease, they're ending up with no therapy options left. And I do think we have to be quite careful about that.